Good afternoon, good morning, good evening for everyone who is attending this seminar. The seminar is delivered inside the NUFIA project. I'm quite sure that most of you know the NUFIA project is something that has been started as a five years project that has been started 3 years ago. It has been impacted very heavily by the COVID, and we have changed during its deployment has been changed mostly to COVID. Today we will talk about training and education during COVID-19, and our aim is to have an overview on the different experience, and I'm quite sure that the seminar will be very interesting. The web package that is mainly focusing on teaching and educate is the Work Package 5, where are present our center, the Regidim in Brussels, and also the group from Romania. So I don't want to go further because we are very restricted in time, and so I am very pleased to give the microphone to Lina, where we talk about COVID-19 training experience in Lebanon. So please go ahead, Lina. Lina? Do we have some troubles with Lina? Okay, go ahead. Lina, can you hear me?
Hello, Monica, are you speaking?
No. So I think that if Lina is not ready to start the lecture,
Hello, Professor.
Oh, good.
Apologies. My apologies. I had some problem with the audio, and I had to log in again. Can you hear me?
Yeah, everybody have problems with
okay, my sincere apologies.
presentations. No, go ahead. No
okay. Thank you very much. So my name is Lina Echeverri. I'm a medical doctor, a master in disaster medicine with the University of Piedmont Oriental and Devrich University. I'm currently a PhD candidate with Trimedin. I worked, and first to say that until yesterday, I was the health director of UK Med and therefore the technical lead for the UK EMT. Currently, I move into a more strategic advisory role. And today I'm going to bring the experience of our deployment in Lebanon. So today, as you can see, I'm going to talk about the role of EMTs in training capacity building. So it's important to explain a little bit for those of you who don't know the initiative. So the EMT, Emergency Medical Team, is an initiative from the WHO. It's a network actually of EMTs, emergency medical teams that are global health force that are ready to deploy to any type of emergency. It was created actually after the disaster in Haiti in 2010 with the idea to respond to sudden onset disasters, but since we have obviously many humanitarian crises, they were proved to be actually very helpful during the Ebola outbreak in 2014 in West Africa. Currently, they were used as well in Mosul battlefield in Iraq. And currently, they are being used massively for the current COVID pandemic. Provides obviously the EMT's health system readiness and support capacity building of national and international teams. The EMTs are classified according to the Blue Book in different types, type 1, type 2, type 3, and currently there are under definitions the cells, so the outbreak cells, the spinal cord injury as well. Today, I'm going to talk specifically about the UK EMT and the activities in Lebanon. So the UK EMT is owned by FCDO and has been verified as a type 1 and type 2. UK Med, which is the organization that I was working with, provides the health workforce and currently the strategic and the technical leadership and as well the coordination on the ground. Currently, the EMT has been deployed, and even with the last deployment to Svatini to 11 countries, it's actually the EMT that has been deployed the most during the COVID response. Next. So, thank you. In particular, I'm going to talk about the experience in Lebanon because it has been actually quite challenging, but as well a very, very interesting environment where we can see the use, obviously, of training and building capacity of the national staff. But before going into the detail for the training activities, I would like to explain a little bit more this the context because it's quite interesting. Next. Thank you. So as you probably know, Lebanon is located in the Middle East, but it still makes part of the Mediterranean basin. Actually, it ranks 40 in the Fragile States Index of 2020. This index takes into account different indicators, social, political, and economic. Some of them are, for example, countries that are undergoing social or humanitarian crisis, migration crisis, widespread corruption, deterioration of public health services, and severe economic decline, for example. And as a matter of fact, Lebanon is undergoing a very deep financial crisis where 80% of the Lebanese lira has been devaluated. Its population is more or less of 6.8 million, but actually 1 million of Lebanese currently live under the below poverty line. It's undergoing a terrible humanitarian crisis, and probably you recall that Lebanon actually has been one of the countries, together with Turkey and Jordan, to actually host the majority of the Syrian refugees and provide, obviously, support to this crisis currently. And according to UNHCR and IOM, there are 1.5 million Syrian refugees living in Lebanon, but as well, they host for the last decades a huge Palestinian community as well. So Lebanon today has the highest number of displaced per capita in the world. So as you can see, they are already undergoing a terrible crisis. And then, yeah, you can go next. Thank you. So I'd like to call this control the crisis inside the crisis. Probably you recall in August 4th, actually, there was a terrible disaster in Beirut where a huge amount of ammonium exploded in the port of Beirut, killing 178 people, leaving 6,500 injuries and 300,000 homeless people, according to WHO. National warehouses were destroyed, and this obviously exacerbated even more all the vulnerabilities and the situation, obviously, that Lebanon is undergoing. This had a terrible impact in the health system and obviously in the capacity to provide and to ensure a health service delivery to the population, not only to the crisis itself, so the refugee crisis, but as well the blast, but obviously to the COVID pandemic. 6 hospitals were destroyed and 20 clinics were damaged. Public health hospitals were ill prepared, and obviously they had a lack of resources. And here I would like to call to your attention that actually Lebanon has a private system and as well a public. Before the crisis, many people were using actually the private facilities, but due to the current financial crisis, many people is actually shifting the seeking behavior and are using the public hospitals. But the public hospitals has been neglected. Obviously, the government doesn't have enough money actually to provide, to pay for the medical doctors, the nurses, to ensure actually appropriate delivery of pharmaceuticals and medical consumables. So as you can see, this obviously rises even the state of emergency of this country. And so what happened with the blast is actually the Lebanese colleagues responded quite well to the mass casualty incident, but unfortunately they didn't took into account in that moment that we were undergoing obviously in the middle of a COVID pandemic, and many of them, they didn't ensure infection prevention and control measures were taken in place. And this cascade, obviously, the COVID cases, and actually many of the staff were infected. Next. So in that particular moment, the UK EMT sent an assessment team to understand obviously the needs due to the blast, but very rapidly, all the teams that were deployed and the WHO, obviously country office, acknowledged that actually the major need was to respond to the COVID pandemic. So they placed a call normally, and the methodology is WHO country offices and the Ministry of Health place a request to the EMT Secretariat, and then that request goes to the EMT community. As such, the UK EMT responded to that request and sent a team, obviously, to support. The health activities were looking at case management, infection prevention and control, water and sanitation, risk communication, and community engagement. But here it's very important to acknowledge that the activities actually has been all the time focused on training and building the capacity of the national colleagues for them to be able to respond to the COVID pandemic. And I would like to make a parenthesis here because, and this is where the webinars and the online training actually came very, very handy. And is we as a team actually had in that particular moment, many challenges as well to send the team. As you probably recall, right after summer in Europe, there was a rise in cases of COVID. And so we had very difficulty to actually withdraw national health system from a variety of countries, because actually the UK EMT is using international staff, not only from the NHS from the UK, but we couldn't manage to send immediately all the teams to support the hospitals. So I came with the idea and contact Dr. Luca Ragazzoni from Trimedin to be able to establish some webinars for us to gain some time. Actually, meanwhile, we could gather all the team and deploy them, but as well ensure that we could provide immediate support and training to the national team. Just to give you a little bit of my background as well, in that particular moment, there were 3 EMTs deployed. So the UK EMT, the Polish, and Samaritan Purse. 6 hospitals were identified by WHO as the hospitals with major needs. These 6 hospitals were divided between the 3 EMTs to provide these activities. However, the Polish team and the Samaritan Purse withdraw a little bit faster after 1 month and 1.5 months. And so the UK EMT was actually asked to support the 6 hospitals. These 6 hospitals are 4 in Beirut, Saida, Buar, and Baabda, Daher al-Bashek as well, and in Tripoli, the Tripoli Governmental Hospital and the Halba Hospital. Next. So what are we, sorry?
3 minutes left.
Thank you. So the key considerations and what is so important to understand the context, and when you plan a training, is actually have the time to talk to your colleagues to understand the knowledge and the skill gaps. The webinars and the learn training must be part of the global strategy. So when we plan with the webinars with Luca, we're actually part of the overall strategy that we had for the support in these hospitals. The training needs to be tailored against the context need, but as well understand the availability of resources. Since this is a country that is, fragile and obviously lack of resources, we needed to comply with the availability of the doctors and nurses to actually assist to this training. We needed to be flexible enough, obviously, to adapt to the topics, but as well the way that we deliver the trainings, overcome language barriers, ensure that they or speak English or French, or that we could ensure at least to have some translators. We ensure the cascade of knowledge, ensure as well the smooth transition from the webinars and the long training to the face-to-face once the team was deployed. We boost interaction and make sure that we were always in constant assessment of their needs. And always remember that this is an opportunity of mutual learning. So not only the people that provides the webinar are learning, but as well the team. So it provides a mutual benefit. Next. Thank you. The webinars, so we provided webinars, but as well we ensure to deliver some podcasts, because not all the time the team in the hospitals obviously could assist to the webinars, so they could at least with the podcast go at home and listen to the PowerPoint presentations. We as well provide clinical case discussion, because they were coming all the time with different questions and concerns, especially on ICU care. we actually deliver just-in-time training for these people and use obviously telemedicine. But the most important is obviously the conclusion and is the relevance that obviously have emergency medical teams in any response, not only COVID, but natural disasters and conflicts, because provide obviously the opportunity to strengthen health services, provide search capacity, either because you deployed a team, but because you can as well be flexible in how you provide that response. You enhance the resilience of local institutions and national staff, and as well ensure knowledge and skill transfer. I'm sorry if I'm a little bit late with the presentation. I will stop there. I don't know if I have more time to continue talking. Thank you, Monica.
Thank you, Lina. I believe our audience can contact us by email if they have any other information. I would leave the floor to the next speaker. Thank you very much.
Thank you. Thank you for the opportunity.
Thank you, Lina. I think that we will have our discussion at the end of the webinar. So there are many interesting things that have been said, and it would be interesting to know something more about, for example, the perception and relevance for the students, for the health workers there, if they appreciate this kind of education or not. I'm pleased now to give the microphone to Eric Weinstein from the US that will have a talk on how to build a plane while flying. Please, Eric, it's your time.
Thank you, Professor. Thank you, Monica, Matt, Lina, other members of No Fear, and our honored guests. This is a definite privilege for me to discuss this topic, how to build a plane while flying. The problem with an infectious disease pandemic is the lack of prior knowledge. So today,
okay, go.
I'm waiting for my slides.
Okay.
Okay, Monica, you go to the next slide.
Can you see my screen now?
Yeah, looks
Okay.
good. So I'm Eric Weinstein. I'm an emergency physician here in South Carolina. I work for Team Health at a small hospital in Manning, South Carolina, McLeod Health, Clarendon. If you look at the map of South Carolina, there's a big lake, and we're on the eastern shore. So you go to the next slide. So we're going to discuss translational science tailored to disaster preparedness and response, and particularly an emerging infectious disease. We'll discuss the fundamentals of a prism of systematic literature review and a scoping review. We'll talk about the paper that we wrote about VTE, PE, thromboprophylaxis, and clinical guidelines, and then the difficulty that we face implementing training in the midst of a pandemic. Next slide. So the No Fear Work Package 5 deals with education and training of personnel and volunteers from existing clinical guidelines, existing best practices to meet regulatory metrics, and the innovative ways that one can teach this in a disaster medicine environment. Next slide. So this is the plane, the city of Chicago. This is 1930. That's Kenneth Hunter out there working on his engine. His brother John is flying. And for whatever reason, they went on a 23-hour continuous flight because they could. They developed a plane that would come and refuel. So they trusted their skills. They trusted their preparation. They trusted their plan. They executed, but there was no training, little training, right? You can't really do this, especially in 1930. And then there was no competency. So this was lacking. But this picture does capture the feeling of risk and uncertainty that all clinicians felt, particularly February, March, April, May, the beginning of the pandemic. Next slide. So you have to employ the translational science spectrum. We as clinicians, We go to basic research, preclinical research, through clinical implementation of public health to develop new approaches. We demonstrate their usefulness and disseminate the findings, which is really difficult in an emerging infectious disease. Their labs are not geared and up ready to go with basic research. The protocols to even study the research or preclinical research isn't there. Next line. So we learned through various communications, social media, as we talked, there were hypercoagulable symptoms during this initial part, and still that we noticed. ECMO catheters, hemodialysis catheters were clotting, despite no DVT on clinical exam and prophylactic anticoagulation medications, Lovenox. There was still clotting. There was anecdotal reports of patients being proned and then flipped over to supine and dying, and then went to autopsy and had PE. These were hypercoagulable labs. They were not DIC. Typically, with the x-rays that we were seeing in sickness, we were seeing DIC typically, but this COVID, this SARS virus was a hypercoagulable virus. So we set out to do a systematic literature review, a scoping review. We developed a clinical guideline to hopefully implement research findings in clinical practice, to develop best practices with the effects on influenced populations. Next slide. So a systematic literature review, in this case, it's very difficult. You really want to develop the bias risk assessment with a systematic literature review to then get to a point where you have data that you can compare, data that can lead to meta-analysis and meta-synthesis. But a scoping review, you can ID the gaps, you can identify the gaps, you can scope out the body of literature. So initially what was coming out of China and then Europe through January, February, March, April was really just observational data. This is what we have. These are our patients. This is the data that we're finding, the lab data, the clinical findings, imaging. So everybody then at that point can look at what was happening to develop some type of analysis of what it was to move forward. Next slide. So in an emerging infectious disease such as this SARS, we could look back at the initial SARS from the mid-200s, from the Middle Eastern respiratory syndrome and other positive sense RNA viruses. We had time to produce and process COVID-19 peer-reviewed literature that was coming out slowly. If you submitted an article since COVID, you know how long it's been taking, because there's nearly 30,000 articles have been submitted to peer-reviewed literature. This then leads to critical analysis of this literature to eventually you have to create some gold standards, but there weren't any. There were no gold standards at that time. Next slide. So we published How to Build the Plane While Flying. We developed a scoping review and we put out some guidelines. You have Ruby is from Team Health. Her field of expertise in cytokine storm. Stan Thompson from Team Health is expertise in direct oral anticoagulants. Roberto was in Milan, anesthesia, critical care, trauma surgeon, critical care in Milan. So next slide. And so our search questions, typical for a literature review, is the D-dimer levels. Now we were taught, and we're still taught, and that the D-dimer level is there, but we really don't count it to mean much. You don't base your clinical acumen, your clinical judgment, your guidelines on the D-dimer. But what was found when a cytokine storm through the scoping review is that a D-dimer that's escalating portends to hypercoagulable state, because the initial findings were that the D-dimer at certain levels had an increased mortality. We wanted to know what was the hypercoagulation evaluation and treatment in the midst of the pandemic. What was the literature? Was there discussions of the hypercoagulation evaluation and treatment? Were people doing non-invasive vascular studies for DVT? Were they able to get people to the imaging suite to look for pulmonary embolism, either through nuclear studies or through CT angiograms? And then how common were thrombotic and hemorrhagic events in the COVID-19 spectrum? Next slide. So just like a systematic literature review, a scoping review, you have inclusion and exclusion criteria. We look from studies from January 1st through 23 April, really just the beginning of the pandemic. English studies, Chinese studies with an English abstract. We excluded studies that did not answer the search question if there were single case reports or papers that just recirculated prior data. Next slide. We were able to get to 130 papers after duplicates 95. Alessandro Costa and I screened. We wound up with 39 papers. Next slide. So we came up with these guidelines. Now, typically you want clinical guidelines to go through a whole process to include a Delphi study. There was no time for this. The data wasn't there. To get through a Delphi study would have been another 6 weeks at the minimum. So we put this out there with the intent for discussion, for the intent for people to look at this in their own shops, because we found 12 other like algorithms in other hospitals that people shared with us. In Milan and throughout the US, we got one from London, where people are already doing this within their own hospital. They're keeping their own data. So we looked at what we knew, and things that we knew were those at risk for clot, for thrombosis. We had to look at specifically. We wanted to look at different clinical settings. The outpatient setting where people were not really that ill, where labs were not necessary. The outpatient setting where physicians obtained a D-dimer, less than 3, because our scoping review showed that 3 times the upper limit of normal began to see increased mortality. And certainly greater than 4 upper limit of normal had definite increased mortality. And our premise with this guideline was to follow and to make sure that the guidelines, that whatever you develop, look for escalation of the D-dimer, and that you have to be aware of any thrombosis. Next slide. So we put this out there to develop a clinical guideline team of scientists at each hospital. Now, at that time, there were shutdowns. There were clinics closed, non-essential services were closed. So there were hematologists that were available. There were people in the lab that were available. There were outpatient physicians, pulmonologists that could have incorporated into an inpatient team to look at the data, literature review, and create their own maintenance of clinical guidelines that they could do within their own hospital. Next slide. Teddy Roosevelt. It's hard to fail, but it's worse never to have tried to succeed. Next slide. And this is the crux here. There are obstacles for acceptance of clinical guidelines that are developed on the fly, that are developed in the midst of a pandemic, because there's lack of evidence. There's an inconsistency with accepted theory, particularly looking at the D-dimer, particularly with this fear of DIC, disseminated intravascular coagulation, in the midst of ARDS. But this is a hypercoagulable state. If you look at thromboelastograms that you could employ, you could show that they're hypercoagulable and not DIC. There are physicians that are fear of the malpractice. They're only going to do what's put out there by professional associations, professional societies. Are only going to follow the gold standard. And then there's people with biases that are very difficult to overcome. But no matter what, as we go forward with COVID or other aspects of no fear, next slide, we have to look at no fear. We can't really practice in fear. We have to base things in science. We have to put forward in science. We have to communicate to those that we're training so they understand where we're coming from and why we're doing things. Thank you for your time. If anybody has any questions, they can get to Monica, and I'll be happy to help.
Thank you very much, Eric. This is very, very interesting. This was typical of the first wave, while in the second wave, for example, we have quite more often problems of hemorrhages due to the fact that probably the use of anti-hemorrhagic drugs were used too much, even in the pre-hospital case. And this brought a lot of, not so many, but a change from hypercoagulation to hemorrhagic situations. So this is very interesting. I hope that will be also some guides to the use, exactly the proper use of heparins and low weight heparinoids, because the problem is that if they are not matched very well with the condition of the patient, they can give disastrous consequences. So thank you very much, Eric. It was very, very interesting. We can move to Dr. Alessandro Lamberti, who will give us a lecture on training in a field hospital. Please, Alessandro.
Thank you so much, Professor. Thank you so much, Monica. Good afternoon. Thank you for inviting me to this panel. My name is Alessandro Lamberti Castronuovo. I'm an emergency physician, currently a PhD candidate at CRIMEDIM. And I'm going to talk to you about an interesting training initiative that in an urban field hospital that CRIMEDIM took part in. Next slide, please. And first of all, I'm going to give you a little bit of a context about where this initiative took place and some information on the field hospital itself. And then CRIMEDIM's role in the field hospital and the lesson we all learned from this experience. Next slide. So first of all, where are we? We are in Italy, in Piedmont, northwest of Italy, in one of its main cities, in Turin. And well, at the very center of this city, a field hospital was erected named Valentino. And we are in November 2020, at the beginning of COVID-19, Italy's second wave. And similarly to what was happening in the rest of the world, also Italy was experiencing an overburdening of its health system. And public health authorities and emergency medical services were trying to find ways to sort of ease the strain to the health system. For example, re-engineering the in-hospital services, trying to expand in-hospital capacities. And the initiative of the field hospital of Valentino stems from this context. And CRIMEDIM was appointed for the creation of the practical, and health-related guidelines, and also for the training. Next slide. So, as I said before, we are at the very center of Turin, and the location used to be an underground parking lot under a park, Parco Valentino, and was reconverted to a field hospital for the occasion. As you can see, the surface is 8,000 square meters, 55 tents, 455 beds, 80 toilets and showers, and the oxygen network distribution was so well structured that was reaching even more than 80% of beds. So I'm not going to give you any technical details about the technical information, but as you can see, the structure was very complex and the logistics was very spot on. And it took the regional government just 11 days to build the whole thing. Next slide, please. And given this context, CRIMEDIM's role was to conceive a model of care that was based on a low level of care. So a model of care between hospital and community. And the model of care was a low intensity hospital with a low level of medical complexity. The guidelines were written by CRIMEDIM's multidisciplinary team. We had emergency room doctors, anesthesiologists, infectious disease specialists. So as you can see, a very diverse team. And we were supported in the creation of these guidelines by the university's clinic, Le Molinette, that also provided us with the human resources, young, fresh, new forces, medical doctors or recently graduated nurses, with also non-clinical specialties like pathologists or surgeons. Next slide, please. And so that's the Valentino Hospital, a so-called step-down model of hospital where patients recovering from severe COVID-19 cases, but not yet ready for discharge home, they were sent to the Valentino Hospital. We have a permanent nursing presence and a nurse-to-patient ratio of 1:30. And the nurses were just in charge of distribution of medication, mobility assistance, and patient observation. As I said, the lower medical staffing levels required, but we had anesthesiologists and ER physicians then in a part of a rapid response team that would intervene in case of clinical deterioration with a clear path, a referral path to hospitals in case of something went wrong. Next slide, please. And Crimidim's role, as I said, you have to imagine the unique setting of this training, because we had a hospital that was built 11 days before, a working team of unexperienced healthcare professionals from university, a diverse team of not just healthcare professionals, but also logisticians and engineers, and a setting of a pandemic, the setting of a disaster. So we decided to divide the training in different parts. So we gave guidance in disaster medicine. What's it like to work in a field hospital? Give some soft skills, like, for example, communication with each other. Of course, IPC information, a swift brush over COVID-19 clinic, and of course, practical information like admission and discharge criteria, where to keep track of patients, ward round, and of course, how do you practically use all the equipments, like, for example, the concentrator, oxygen concentrator, monitoring and saturation. Next slide, please. But I have to say the most important and rewarding experience was the simulation. You have to imagine we divided this scenario in 4 different parts from the very beginning, from the very start of the admitting the first patient to the discharge. So we divided it in triage. Where do you examine the patients? Where do you actually place the patients among the 455 beds? How do you do the ward round in such a peculiar context? And what happens if a patient doesn't feel well? If there's an emergency intervention, who should intervene? Who should I call if I'm a medical doctor? And we introduced the so-called disaster in a disaster, so this element of a surprise. So we are in an underground park in the middle of Turin. What happens if one of the oxygen supplies explodes? Or what happens if someone wants to break in to the hospital? And so, of course, it was super important to have the simulation exercise. It helped interestingly, it was helpful for the use of equipment for practical things. Like, for example, how do you turn on the oxygen concentrator, the monitoring equipment? How do you call the other or the rapid response team? And it was useful because it oils the mechanisms and the paths in the workflow. It improved the communication, and it was even practically interesting for just associating faces and profiles to sort of a who's doing what kind of thing. And also we realized during the simulation that, for example, we didn't have the telephone numbers for the rapid response team. So of course, something that was very important. Next slide, please. Of course, what's the lesson learned? It was interesting for our group, for Crimidim's group, because all the brainstorming and talking about what kind of model of care do we want to implement in this hospital. And then we decided that a low intensity care, a so-called step down model would be ideal in this context, in an urban setting in the midst of a pandemic. It was interesting to prove the role of Crimidim, of the facilitating role of Crimidim among these diverse profiles of people coming from universities, people coming from non-health related sectors like engineers and logisticians, and even fresh new colleagues that had never previously worked before. And of course, I just want to stress the importance of simulation in such context to make everything run smoothly. Last slide, please. Thank you so much for this opportunity.
Thank you very much, Alessandro. It was a very interesting talk, and congratulations also, because to have built this kind of hospital was very important for our region, because it gave the possibility to admit patients that otherwise should have created great disasters in the region. And with this, we could have an escape way for getting people at least a good assistance, at least for the patients who didn't meet any further level of assistance. Education was one of the most important points to allow this hospital to work. And the system did it, and we gave a great help to the people of our specific region. Thank you, Alessandro. I will give the micro now to Anja Westman from the University Hospital for Örebro, Sweden.
Sorry to interrupt. I think now it's turn of Ben Kimsky.
It's time for Christine.
Yeah, no, thank you so much, Monica, Francesco, and also Eddie as well for inviting me. I might just share my screen. Let me just see if this works. Wonderful. Present. Beautiful. So again, I really firstly appreciate Eddie for inviting me. I've heard about the No Fear project. I've seen it around, but obviously I'm in Australia, in Sydney at the moment, so the time difference is often quite challenging for me to attend your events. For I stayed up quite late tonight, got night shift tomorrow night, so it's a good preparation for that. And yeah, really appreciate and quite honoured to have been invited to speak. My background, let me just, there you go. Hold on. My background, I'm a paramedic. I actually originally trained in Israel and have then qualified in a degree course in Melbourne and currently working with Ambulance New South Wales in Sydney, and also working as a Director of Training and Strategic Development with Real Response. So what I'm going to talk about today is a serious game, extended reality training for emergency and critical care practitioners. So as part of my work with Real Response, we have a serious games team where we have developers, 3D artists, etc., who are doing some pretty cool stuff to allow future technologies to assist emergency care practitioners, military medics, pre-hospital practitioners to train in quite high fidelity simulation without the need for face-to-face, which obviously in a COVID environment is incredibly advantageous. I'm going to show you a couple of quick videos. This is just a short video now.
To save lives by preparing people for the realities of emergency situations. We do this fundamentally through simulations. Think about a plane crash or a major construction collapse. Traditionally, we would use big scale simulations, which would be very expensive, very difficult, and sometimes just way too dangerous to do. With extended reality, we can put that whole scenario into a virtual setting to allow our students to experience it safely in a way which can be replicated and assessed in a very cost-effective manner.
Our serious games team is capable of developing realistic training simulations that can be used across various industries. We pride ourselves in delivering training that gives real results for our learners. And we do this because of the experience that we have, not just with technology, but also with our education side. This means that our training products really focus on the learning outcomes for our clients.
We have an incredibly powerful team of highly experienced people, all with first response experience. We don't have people coming into our team who don't know what it's like out there responding to emergencies. And we see the need for organisations to have access to high quality training wherever they are. Think about how many people you need to train 10,000 staff. It's incredibly logistically challenging. You put this into VR, you send the devices out to all of the locations, you get them to do it in their own time, and it's all assessed. This technology was once the dream of science fiction.
So I'm just going to cut there, and I really apologize for the salesy side of that video. But what I wanted to really show you is a little bit about how, as I'm showing in the last presentation, some of the simulation-based work that was done, and obviously it's incredibly time-consuming, expensive, logistically challenging, not to mention dangerous, and in Australia absolutely impossible, where we're having state border closures every other day, not to mention the rest of the world. So what we've seen, we've been doing this for a number of years in VR, but what we've seen since COVID is a massive uptake in organizations turning to virtual reality as a way to assist them to get some form of training where they cannot come together for face-to-face. So a little bit about the headsets, and I'll show you why this is so incredible. Let me stress, this is not my prices. This is the prices I found on the Oculus for Facebook website. We don't sell this stuff. But the reason why I'm showing you the prices is just to show you how incredibly cheap this stuff can be. Each headset is so incredibly cheap. So that capability of scalability to go, all right, we have, in Australia, our country is massive, absolutely massive for those of you who've been here. So we're talking about paramedics and doctors that might live, the closest backup might be hundreds and hundreds and hundreds of kilometers away. The mail is flown in on plane because it takes too long for any other way. We're talking about incredibly remote and isolated places. So for somebody to send a trainer out to those places, assuming there aren't any restrictions around COVID, even just to send a trainer out to those locations is so difficult in our context. The fact that we're able to package small little cases like this, which cost very little, so they can, if they break, it's not great, but it's not the end of the world, means that we're able to scale this training at an unprecedented level. We can put one in the post, send it off to really anywhere in the world, and it's working incredibly well. I'll show you something that we're doing, which is, this scenario is something we've actually done for the military, and this is a MedEvac scenario. And again, even the military in Australia are having massive issues with getting from state to state. The Army School of Health, which trains all the medics, are in one location. We've got a number of health battalions around the country, and then we obviously have our medics on deployment all over the world. How do you maintain skills governance over those people when you can't fly them back to a central location to train them? So I'll show you this little scenario that we've done at the moment. So this is I think is a 7-year-old kid with measles and he's septic on a Pacific Island humanitarian mission. So you're able to do pretty much all the interventions as you would in your resus bay, or so we've included point of care ultrasound in this, and you can do most applications in this. So this is something that we're using at the moment to train predominantly ALS practitioners. The beauty of this, not only can you train remotely, but it also assesses the user remotely. So the user can put in their employee ID and before they start, it assesses them, it grades them, and it actually loads on a learning management system, so the user, back wherever they are, is actually able to see if they've completed or not. We even have an AI capability which adjusts the difficulty according to how the user is going. So if the user's struggling, it's a bit, the AI makes it a bit easier, vice versa. So this is another little scenario that we're doing it, and this is for industry. So this is for basic life support for first aiders who again can't access traditional simulation and traditional high fidelity training, which we once did face to face. So we have the capability of multiplayer in this. And what's we're really proud of with this is we actually rendered this scenario from a real world environment. So if any of you have been to Melbourne, if you know Frankston, it's just a few kilometers north of Frankston, Chelsea train station. And you can see the real world pictures here, as well as the virtual visualization, which our 3D artists put together. So we have that capability of actually rendering real world environments, which you've done for here. So when we're talking about disaster preparedness, this is quite an amazing capability. We're growing pretty fast in this field, and we're doing some really amazing stuff. I think, I know I've got to finish it in a minute or two, but I think when we're talking about future technologies and VR, extended reality, mixed reality, a lot of people, it's a very sexy term, and a lot of people want to jump into it without necessarily understanding what the learning objectives are. And I think if anybody in this call is actually thinking about delving into this within your organization, I think the first thing is really to articulate what are the learning objectives. I get this all the time from people saying, why don't you do CPR in VR? Well, why? It's going to cost us a lot of money to do. You can literally buy a $50 mannequin and probably do a better job. So it's really essential that going into it, it's about understanding the limitations of VR and not trying to do everything in it. The way we use VR, we start off with a learning package, either that's an e-learning package, a webinar, a face-to-face lecture, if we're allowed. We then go from that to skills. We then go from skills to a virtual reality scenario. And then we go from the virtual reality scenario to a real world scenario. And once we achieve that real world scenario, we're going to get a lot better value for our money out of that real world scenario, having gone through that step process. And obviously in situations where we can't meet face-to-face, VR is performing a significant role in that training, although it's still not face-to-face training. It's not a replacement for face-to-face training, which is something I think we always need to remember the limitations. Star Trek Holodeck is not there yet. And even if it is, it's still not a replacement for real simulation, and real simulation is still not a replacement for real world experience. So I'd like to thank again Eddie for inviting me, Monica, for organizing everything. Again, it's been an incredible honor to be able to present to all of you today. My email address is down below, and I would love to hear from anybody if anybody would like any more information. Thank you so much.
Thank you very much, Benjamin. I would invite you to go on the chat because there are some questions for you, and a very good presentation, and also very innovative. And we would like to go in a deeper knowledge about what we are doing. This my vision. This is very interesting. So I have the pleasure to move to the next speaker, who will be Catherine Bertrand, Eric Carpentier. They will present on training EMS and other new human resources.
Thank you, Francesco. Next slide, please. Okay, the COVID crisis has affected the way we teach and forced us to adapt because of the lack of availability, the obligation to devote teaching to the COVID-19 to the detriment of other teaching, the need to rapidly train a large number of staff in new tasks for them in order to strengthen our teams at the dispatch center, for example, and in ICU especially, and to train more volunteers than usual. And we change our habits in favor of remote learning, virtual classroom, except for emergency gesture, and live online classes. As a result, many videos have been shot for mass training. I will focus on this. Next slide, please. We are lucky in France to operate in large family networks at a national level and to work closely with the Ministry of Health. And on this slide, you can see the logo for the Ministry of Health, the logo of the national school, which trains hospital directors and has multimedia capacities, the logo of SAMU de France, the logo of our teaching center, CESU, the logo of 3 societies that were especially involved during the crisis: the Disaster Society, the COREB, which is a Society of Infectious Disease, and the Society of Geriatric, because of the importance taken by nursing homes. Next. In March 2020, the Ministry of Health asked us to create storyboards for healthcare professionals. And you can see a list of 11 short animated videos that you can watch on the ministry's website. Of course, it is in French. Next. In addition, Santé Publique France publishes posters in about 20 different languages. And I also give you the site and you can watch all this. Next. We had to continue our emergency lessons in a different form with videos on patient care. And we have been creating multimedia tools by combining text information, photos, and videos. And the objective was to let healthcare providers learn from everywhere at their own pace. And here is an example for our colleagues in Guyane. Next. We also had to transform our congresses into virtual congresses with interactive sessions. And you can watch the professor on the right side of the slide, drawing what the messenger RM does in our cells. Next. All the tools are put on the our teaching center, the national one, website. And you see the link also if you wish to know more about this. Next. We have also worked with the Geriatric Society because of the importance taken by the nursing homes. And here you have the list of short YouTube videos that you can also watch. Next. What was new for us was that we had to train volunteers, firstly, to reinforce the intensive care units. And recently, the government wants us to train 20,000 volunteers to carry PCR tests. We collaborated to the creation of an e-learning program of several hours. And I must say that I obtained my certificate, but I had to redo 2 quizzes. And SAMU is responsible for training the trainers. And my first session will take place next Friday. Next slide. In conclusion, videos help people to learn by using visual content. But I would say that, of course, we have a lot of support of tools, but we don't assess their impact. And our task will be to be open to train new resources and to create new trades. And to be honest, sometimes politics interfere with our scientific messages and we have to redo what we done before. Thank you very much. I hope I gained some time, but you can look all what we done on the sites I mentioned.
Okay, thank you very much, Catherine. I am sure that it was needed everywhere to open the doors to other specialists. In fact, they responded very well. Unfortunately, the responses, at least in Italy, was much higher during the first wave, while it was declining in the second wave. So, but we can discuss it at the end, because I have no reason for that, but the situation is that they responded less unanimously to the call that we gave them, either in the intensive care and in the EMAs. Yeah. So thank you, Catherine, again. We can move to Dr. Shavitz Botner from our friends from Tel Aviv. The title is COVID-19 training related issues in Israel. Please go ahead.
Hi, good evening, good morning, good afternoon, everyone. Thank you for having me. And it's always nice to meet people that were here. Hi, Ben, I hope you remember your experience here in Magen David Adom in Israel. So we are going to speak about, as you say, the COVID-19, the training related issues in Israel, and particularly in Magen David Adom. Next slide, please. So for those of you who are not familiar with Magen David Adom, MDA as we call it, is a national EMS. It's quite unique around the world, which one EMS system is the only one, or almost the only one in the whole country. And Magen David Adom MDA is spread, as I said, all around the country. And we are dividing the country to 10 regions, 10 geographical regions. And we have around 200 or 200 and something ambulance stations around the country. And the Paramedic Education Center, our school, is responsible for certificate all the paramedics in Israel, and it's around 350 paramedics annually. We're also responsible for the CME, and as I said, we are having on regular days, we are having students all around the world, like Ben from Australia, and that's what we are doing on regular days. Next slide, please. Oh, that was the first one. Thank you. Another one. Thank you. So during the COVID or the last year, we had three major issues that we had to train all our staff. The first one was at the beginning of the situation, almost a year ago, was to train all our staff the donning and doffing procedures, how to do it right. The second one, which is of course not of our daily scope, is how to do the swab test as a procedure during regular days. Of course, EMS teams are not doing that, and in Israel, because we are a national EMS, it was our job. We got it from the government, from the Ministry of Health in Israel. We were responsible with the first one that was, we were needed to go to the people's home and to do the swab test. And later on, we had the drive-through centers, walk-in centers, nursing home, and all kinds of projects that we got from the government. And of course, we were responsible to, because of our widespreading all around the country, we're responsible to check all kinds of COVID-19 detection kits instead of the swab kits. And luckily, in the last around 2 months, we are responsible, or even less than a month, we are responsible for the vaccinations at the nursing home and the elderly people in Israel. So we had to train all our staff the vaccination procedures. And as you probably know, it's kind of rigid restrictions with the Pfizer and Moderna. Those are the vaccines that we have in Israel. So there's a specific way how to prepare the vials, how to dilute them, how to prepare the syringe. And it's in Israel, in the EMTs in Magen David Adom are not trained to do intramuscular injections on a regular basis. We're not trained them to do that on their basis training. So we had to do this as well. Next slide, please. So as I said, we have few challenges. It's not the scope of practice. Of course, not the swabs and not the vaccines. And for the EMTs, not the intramuscular injections. We had to do a mass training in a very short time. We had to react like the rest of the world. And of course, all of you, we had to do it in a high rate of updates because as you all know, all kind of updates regarding the PPE or regarding the swab procedures or regarding even to the vaccines we had to do it very fast and to update all our staff. So of course, all kind of training we had to divide it by two. First, the theoretical part, and later on how to do the practical training, the hands-on training. So those was our two major challenges. So how we did it. Next slide, please. The theoretical part, we of course used all kind of computerized solutions like video conference. I remember myself a year ago when the first time I saw the word Zoom, I was like, what is it? So of course, everybody now know what Zoom is, Teams. We're using the Moodle, which is a computer software, and that helped us to do all kind of e-learning. Of course, we build presentations and we filmed targeted videos for each kind of subject. And we built a specific or special cellular application which all the staff in Magen David Adom can have all the theoretical part, what we call in his hand 24/7. Next slide, please. And on the practical side, the Paramedic Education Center, my school, was responsible to pass or to train at we call it the state level, the highest level on the hierarchy. And below us, there was the supervisor paramedics, which every region of Magen David Adom has a supervisor paramedics. And they're, of course, spread all around the country. We trained them, and they were doing small hands-on groups practice all around the country. And by that, we practice actually all our staff, and we will see the numbers in a minute. Next slide. So about the self-learning and updates, as I said, everything was online all the time. We built a cellular application. All the staff, all the student has 24 hours and all-time access to the Moodle and the intranet of Magen David Adom. And of course, updates that were from now to now, from minute to minute. We spread it first via the social networks, which of course everybody use it today. So what were our numbers? Next slide, please. So if we're talking about the first challenge that we had down in Dofing, we trained about 30,000 people that were trained how to do these procedures as they needed to. And that was, of course, very fast at the beginning of the situation. Later on, the swab test that we trained our staff, we trained around 8,500 people, and they, until those days, performed around 4 million swab tests. And if we're talking about the last month and a half, 6 weeks, around 6 weeks, the vaccines, we trained 2,500 from our EMTs and paramedics, and they finished today 180,000 inoculation, which means double it by 2 because every person needs 2 doses of the vaccines. So that was our way to challenge the challenges that COVID-19 put to us as a trains, as a school, as people that train people all around the country. So thank you very much all. And of course, if you have questions, so feel free to contact or via the chat.
Thank you very much, Rashid. Shafit, is it? Is it right? It's difficult to say. Anyway, I think that your lecture demonstrated how much the new modern tools that we have at our disposal improve the rapidity of response, because otherwise it should have been impossible to react all together all over the world. I think that the exchange of information and the exchange of use of modern tools gave us the possibility to get the knowledge very, very fast on what the changes were. So thank you very much. We can give the microphone now to Eddie Versilowski, who is a ViceMed LTD representative in Israel. He will talk about the medical device training during COVID-19. Please, Eddie.
Thank you, Francesco. Can you hear me well?
Yeah, absolutely.
Great. Thank you so much for the opportunity. I think it's a great idea to organize this webinar, since a lot of those questions rose at this time, and it will be a good opportunity to present another part of the training aspect. So next slide, please. So Persis Medical is a conglomerate of several companies that produce tools for emergency medical interventions. It's mostly for pre-hospital teams, but also for hospital, military, and law enforcement. We focus on one side niche, but a unique market of intraosseous access, hemorrhage control, hypothermia prevention, and airway management. No, previous slide, please. Yes, thank you. So the tools that we make, and not only us, but I speak in favor of many other medical device companies, and their tools require frequent training. And this is because of, we want, as a manufacturer, we want to be sure that the end users perform the interventions correctly, and that no harm is done at the end of the day to the patients. And that's an opportunity to put that on the table, that we are also responsible by the registration to actually maintain a high quality of medical device. And a part of this maintaining of quality is making sure that the end users do what they are required to do. And for that, we needed that frequent training. Just for example, one of our devices that are intended to be injected in the bone require an annual training. And for that, we were required to at least meet the end user once a year. So we used all the opportunities, starting from customer visits to medical conferences and trade shows to do those training and refreshers. Next picture, please. One more. This is the classic environment that we used to operate in. Next picture, please. And this is where our salespeople and clinical application specialists are feeling at home, those trade shows. But last year actually changed the whole this whole area of operations for us. Next slide, please. And we actually refer it as the new reality because we don't know when all those shows will be back, and actually, as a matter of fact, we don't know if they will be back. As we know for a fact now that virtual shows are not bringing the benefit that we were expecting them to bring, so we actually need to adapt. So we cannot visit users. This is because we have no flights, and mainly because of our end user target population is actually busy with saving patients. So they don't have time for us, and this is totally understandable. We cannot do the hands-on as we used to, meaning that we need marketing materials which are much more attractive, and we have a lot of inquiries from our customers and end users asking for some materials, some refreshers, videos that they can see on the breaks or something like that, for them not being too long because they have no time, and for them being attractive enough to learn something from. So this is our new reality. Next slide, please. We do expect that we will decrease our customer visits dramatically, even given the situation that in the next month everything comes back to normal, which is a totally wishful thinking, but let's think in this way for a second. We don't believe that we will go back to visit our customers as we used to. We are starting to be more and more reliable on remote training, and the sessions are becoming shorter and shorter. So our classic session is a 1 hour training session. Most of our sessions this year did not exceed 30 minutes, and we believe it's too much as is. Which brings us to the challenge of investing in local trainings, in local trainers, as actually physical persons that we will train remotely, and they will do the hands-on and the customer visits for us. On one side, this is a big burden. The salaries and the maintenance of the skill. On the other side, taking into considerations that we have no travel expenses, it may be beneficial. Most of our distributors, we are a manufacturer and we rely on distributors. They hold a portfolio of devices, and when they are not visited, we are kind of forgotten. So we need to be remembered, and let's put it on the table. We are a manufacturer, and we need to sell in order to maintain ourselves, and in order to continue and produce good devices and do a good research. So we need to be remembered, and this is definitely a challenge which we are trying to tackle in 2021. Next slide, please. We see it as an opportunity as well. We do cut down the travel costs, as I said. We develop new e-learning opportunities. I totally agree with Shafir and Ben. We go in that direction too. We believe that e-learning is here to stay. It's not going to disappear anywhere. It's going to develop. Our media and salespeople are becoming much more creative those times, just to gain more attention from this short time that they have with the customer. We do believe that VR training will take more and more place in the next years as it becomes cheaper and as it delivers what it needs to deliver. We believe that there is a place for it to develop. And for us, and this would be probably the last thing I will say, for us, we need, as a manufacturer of medical device, we need to hold a proper quality management system which relies on customer feedback. So usually we relied on private visits on face-to-face visits to gather that feedback, but not anymore. And we actually see it as an opportunity, because if we already do those virtual sessions, we can gather feedback at the end of the session. It's much more convenient for the users to just go into a web questionnaire while they are on their devices already, which will actually improve our system dramatically. So thank you for the attention. I will be happy to answer your questions in the chat. Thank you, Francesco.
Thank you very much for your presentation, Eddie. I think that it was a very interesting insight in education tools and the new needs for training in COVID times. I think that a real challenge, and we do not need to postpone our decisions, but we have to take responsibility for a change in methodology due to an external fact. But the reason is that we cannot go on, at least in these times, to continue with our usual training. So, but if we have time, we can come back on this in the discussion. So I'm very happy to give to our friends in Brussels the microphone for discussing about lessons learned and actions regarding training during the first and second COVID-19 wave in Belgium. Please, Yves.
Thank you, Francesco. Thank you all for being present during this Work Package 5 webinar of the No Fear project, in which our center is also involved. And what I just wanted to present to you all are lessons learned and challenges that we faced from a hospital disaster preparedness point of view during the first and the second COVID-19 wave in Belgium, and actually probably also in the third wave, we started a week ago. So next slide, please. This is just a short information slide about the hospital where I work. It's a combined hospital and university nursing school campus called the Brussels Health Campus, University Teaching Hospital, Level 1 Trauma Center. And also we are taking part with our rapid response cars in the EMS of Brussels, of the Brussels capital, the SAMU as it's called in France. I will come back on that later also, discussing about training. So next slide. This gives you the current situation in our hospital. On the left, you have the first wave. It's in Dutch, but I will translate it to you with the current admissions in green, light green, and in the red is the ICU admissions. And you see on the right side the second wave. And if you really look at the right side of the slide, you see that curve of ICU patients and also slightly the normal admissions is going up. And so we are confronted now with the invasion by the British strain in Belgium, and this is now challenging us again. Next slide, please. Regarding training and education, I would just like to focus on those 5 aspects, especially on lessons learned and challenges and actions we had undertaken in the first and in the second wave, and also still going on at this moment. So next slide. Regarding the training of reallocated personnel, and I think it's similar to other hospitals around the world, that each department was actually responsible for organizing their own training. And I mean by that ICU is responsible for training reallocated personnel to ICU. We as ED were responsible for training those nurses and doctors from other departments that were allocated to our department. So this was also targeted to the specific needs of that department. In the ED, we use the principles, and we heard it already by mentioning by other speakers, by the just-in-time training, which seemed to be a very good approach, which worked, and which I think can be considered in this kind of settings as a best practice. We also developed several crash courses for personnel being reallocated to the ED. So we and other speakers also said it, like Katrine said it, but also Eddie. We used e-learning and other kinds of electronic systems to train our people. So like a COVID for beginners, handling the PPE, and also people that came to the ED and were not used to work in the ED, we had to explain how it worked, also in the new environment with COVID and non-COVID areas, etc. And as we have a very advanced electronic medical record, we had to train them in using that electronic medical record too. Next slide, please. Our own personnel, the focus for our own personnel. So actually COVID was what we saw associated with specific needs and practices. And also here we developed several crash courses for our own personnel, like difficult airway, principles of invasive ventilation. You will see this was especially the case in the second wave as our ICU, and I will discuss this in a minute, as our ICU wards were a bit overloaded as regular care also continued to take place. So we were confronted with the regular care and the COVID care. Also principles of non-invasive ventilation, which were already known, we had to repeat them and rehearse them again. And as I said, lung protective ventilation, which is very typical for ICU, but not for emergency physicians, had to be, we had to train them on that also. And so, as I said, during the second wave, our challenge was especially there in preparing the ED for bridging ICU patients. So we, unfortunately, we were never overwhelmed as our Italian colleagues and our Spanish colleagues in the first wave, as patients stayed already in the corridors of the ED before they have been transferred to ICU. We never challenged that, but in the second wave, this challenge was really there, and so we started to train our personnel, nurses as well as doctors, in specific ICU skills, such as I said, lung protective ventilation, prone positioning, and for the nurses also specific nursing aspects. We did that with simulation training. We did that with courses, with hands-on. So several methodologies were used to do that. Next slide. I think this gives you a bit of an illustration of a hands-on training on prone positioning that was led by ICU personnel, and they came to do this in the ED. These are pictures taken from the ED early October a few months ago. Next slide. A specific point that I want to tackle here is training and education related to stress and well-being. As you know, and I'm not saying something new, that there was a lot of uncertainty and fear amongst all the personnel because of the unknown of the COVID-19. And what we noticed that mental well-being is at utmost importance during a pandemic, and actually identification of burnout or stress factors needs to be very quick and efficiently there. So training in handling stress and coping mechanism, besides the response to treating patients, also the training and handling the stress and the coping mechanism for the personnel actually should be organized as soon as possible. And now we are there with trainings in mindfulness and etc. But I think this is started a bit too late before and should be done in the beginning. And I'm coming always back on the PPE. The most important stress factor for our personnel was, okay, do we have enough PPE? Is the PPE that is put available to us, is it safe? Is this validated, etc.? As there were a lot of lots of orders that were circulating that were not actually approved as being an FFP2, and this caused a lot of stress. So the mental well-being was a very important issue also in the training. And so we are now training our personnel separately, like nurses and doctors, in mindfulness, etc., to cope for those issues. Next slide. A special issue is also advanced care planning, as we had to make choices between putting patients on ventilators or not, or going even in the ED, installing do not resuscitate orders, etc. It was also important to address this from the beginning. And actually, we set up a very good task force, a multidisciplinary task force with ethicists, with infectious disease specialists, with ICU specialists, emergency physicians, etc., and made actually a protocol there for advanced care planning that was also trained to our providers in a specific way in intensive care, on the wards, but also in the ED and even in the EMS, where we saw that it was very important to start a resuscitation or not in the framework of COVID-19. And the importance of the debriefings on those cases were actually, for me, an example as a training momentum. So we use the debriefings on the difficult cases as a training momentum for our personnel to see how they apply the protocols, yes or no. Next slide, and this I think will be the last one. As we are similar to France, our personnel is involved in the EMS, in the pre-hospital. Also there we had to take some actions on training and education. And again, the training in the use of the PPE, how and when to use the PPE was important. It was a little different aspect than in hospital, as we need to keep our fast car as clean as possible. There was also, and we discussed, I think, this in a webinar on the pre-hospital, where we tackled within the No Fear, we tackled the disinfection procedures outside hospitals for ambulances, etc. Also here, the disinfection procedure for our fast car was also an issue. Airway management in the pre-hospital scene is a bit different than in the hospital scene, because you're in the field, in the middle of nowhere. How to handle that difficult airway, how to protect your personnel when intubating, etc., is a bit another session. And I think Catherine also focused on that, and we used also like small videos and other things to train our personnel, similar as you did in France. Also, Eddie, this is the medical devices we used, okay, the ventilators and the other things, how to keep them clean without destroying them was also an issue. And so these were all things that we needed to train our people on those aspects. And then finally, as I said a few minutes ago, training in the advanced care planning and the mental well-being were also very important in the pre-hospital setting, as our people were sent out in the field, in the middle of nowhere, where they were confronted with the unknown and the unexpected. So I think this was the last slide. The next one is just giving you a nice view of the atomium, as I'm using always this as my final slide. So these 5 elements for me were very important regarding training and education. Thank you so much.
Thank you very much, Yves. I think that you gave us a very thoughtful consideration about the relation between education and stress. I think that this is a very, very important point that should be taken into consideration if we would organize in the next future a specific topic on the consequences of education and training in the performance and in generating stress. So thank you again. We will move to Erdicho Corral Torres from Madrid, who will talk about how pandemics changed the way of providing training to paid staff and volunteers in Samoa PC. Please, Vijay, it's up to you.
Yeah, good afternoon, Francesco. Good afternoon for the 47 participants that are online now, and good afternoon from Spain. No, and thank you very much for allowing us to share our experience. No, next slide, please. This is the normal situation previous the time, the scenario of COVID. No, some would do its organization has professional and volunteer on this staff. Currently, 900 professional and about 1,000 volunteers. For many years, training and SAMUR has not been elective. By union agreement, each worker must receive a mandatory training on 32 hours in working hours. In addition, the organization must also provide another number of hours that are elective for the worker and are compensated with 3 hours if they do them. Next slide, please. Next slide. Please. Yes. In the case of volunteer, it's something different, of course. No, on the one hand, some would annually organize 3 entrance promotion of 100 new volunteers in order to keep the volunteer staff stable, since it's a significant turnover, of course. In addition, it is necessary to carry out training in specialization and recycling for the volunteer who remain in the service. No? Next slide. That is why, for us, there wasn't the possibility of suspending training as happened in Spain, in universities, college, and school in the first part of the pandemic. No? Therefore, we had to adapt, yes, but with 2 principles to carry out the new strategy. Maintain as many actions as possible of the planned program, fulfilling our commitment and maintaining our quality standard. This adaptation implied, on the one hand, adapting to the new security condition, and on the other, adapting to new pedagogical forms without renouncing the educational objectives. New slide, please. Thus, we prepare professionals with an online course on digital skills so that they get used to this new model. We carry out several courses through the Moodle platform, just for example, as the online ECG course that I show here, with good evaluation results, but lower than the face-to-face training. Next slide. But our main objective was to maintain face-to-face training, even in this COVID scenario. Adopting the logical security measure, we continue to carry out face-to-face training with a lower ratio of students, of course, and we even hold monographic sessions with the blended model, with a reduced number in the room and with most of the capacity online. Next slide. As for the volunteers, we continue to maintain the 3 entrance promotion. The first of them, which was being carried out when the confinement was decreed. We had to change it to the online mode with a streaming class in most cases. Although the model platform, we also use it for some courses. Next slide. The essential modules of CPR, clothing and undressing biological protection with practical individual class in many situations continue to be carried out in person with adequate security measures. Next slide. Finally, and in conclusion, it was possible to save most of the planned training plan, maintaining the content of the program in 80% of the case, more than 250 training action in 1 year, in this 1 year, with results of student satisfaction very similar to those of the previous year. But it's clear that, and we have observed that the student preference for the face-to-face training. That's all. Thank you very much for the opportunity to share with you this experience.
Thank you. Thank you very much, Elvijo. It was a pleasure to meet you again. If you remember last time we met in France, where they were asking to the Italians why you don't have COVID. It was at the beginning of October. And I think it was just a matter of time because we were invaded by COVID just a few weeks after that meeting. Anyway, thank you very much. It is very important how we are facing education and training in COVID times, I think that we don't have to surrender to COVID at all, but we have to find out some different measures and way of teaching that should adapt our situation, our activities in this specific activity that we have to do. So I have the pleasure to give the microphone to Madalina Dușiș in Bucharest, in Romania, and she will present us about the situation of education and training in her country, in Romania. Please.
Hello all. It's very nice to see you again, and thank you for inviting me to present the situation in Romania. First of all, I would like to tell you about the first confirmed case in Romania was on the 26th of February 2020. And by the 14th of March, Romania exceeded 100 confirmed cases. And on the 26th of March, the total number of confirmed cases already exceeded 1,000. And so there were serious concerns that the healthcare system would be overwhelmed if the infection rate continued to increase. This would have been a serious issue, as you probably all know, the Romanian healthcare system faces a problem of understaffing due to the continuous immigration of medical personnel. Next slide, please. Another issue was that in Romania, the majority of medical services are provided through the public healthcare system, which still largely relies on old infrastructure built under the former communism regime. So in this context, considering that the hospitals in Romania have a certain structure, it was difficult for hospitals to create separate corridors for patients with suspected infection, compared to other patients with other pathologies who are not infected with COVID. Taking into consideration that the old infrastructure of the hospital was not designed with such separate circuits, so hospital had to find solutions to separate patients and avoid interactions between infected and non-infected patients. For example, in Târgu Mureș, where one of the largest emergency departments in Romania functions, the yellow area of the emergency department has been reconfigured into the area for receiving patients with suspected infection with the new virus, with separate patient entry and exit circuits. Next slide, please. As infections started to be reported among medical personnel, many wards were closed and patients with other conditions were either transferred within the same hospital or to other medical facilities. So one other solution that we found was to organize smaller hospitals specifically for patients infected with the new virus. There was also a challenge with a CT scan, as most of the hospitals in Romania have only one such device. So in most of the hospitals, there were created separate entrances to CT scan, which was to be used for both patients, those infected with COVID, as well as for the rest of the patients with other pathologies, with subsequent disinfection after each use. Next slide, please. Just like in every other country, due to the social distance, no more meetings were held, and all the information was being sent by email or through other online communication channels. Most of the departments in hospitals would create groups on different social applications and share information about courses, tutorials, using this means of communication. So webinars and virtual meetings, online courses, providing important knowledge and information, not only for residents, but also for the practitioners. Next slide, please. There were also difficulties in teaching the medical staff from the COVID area to undress the protective equipment correctly without being contaminated. In this sense, in most of the hospitals, groups of 5 people were formed who were instructed on how to equip or disassemble. They would record this and later send a tutorial by email to all the medical staff. At the beginning of the pandemic, It was also difficult to train younger colleagues, specifically resident doctors, to use the video laryngoscope instead of the classic laryngoscope. And in this sense, the mannequin was practiced in small groups, and also tutorials were sent to the other users. Next slide, please. To minimize the risk of infection among medical personnel, hospitals had to come up with solutions. In this sense, in most of the hospitals, it has been decided to form shifts made up of the same people. Also, accommodation was provided for medical staff who wanted to isolate themselves from family members. And this was possible with the help of certain businessmen who provided their hotels or apartments as accommodation for medical staff. Next slide, please. Next slide. For the 112 integrated emergency dispatches, we also had a big problem here with infections among personnel working in the dispatches, as most of the doctors from the emergency units and from the ambulance services initially performed shifts in the dispatch. Thus, the risk of those who were also working in the field directly with a COVID-infected patient to infect those in the dispatch center was very high. So in this sense, certain doctors were appointed to carry out all the dispatching shifts in order to diminish the risk of contamination of the other people working in the dispatches. As a first step to protect emergency medical crews from becoming infected with the COVID virus, so the crews that were going to the patient with an ambulance, the staff working at the dispatch center was instructed to ask each caller whether the victim showed specific signs of infection. So where no information could be provided, the emergency crews would wear the protective equipment right from the start, taking into consideration the possibility for the victim to be infected. For the modular hospitals that we organized in the country, there were problems in quickly qualifying staff to deal with critical patients, as most employees were fresh graduates from health school or from wards with non-critical patients. So in this sense, the training was carried out with the help of the emergency department and intensive care units personnel, who were organized in small groups, and they were instructed through online materials made available to staff. Next slide, please. So for the pre-hospital staff, medical personnel was trained locally with regard to the guidelines for basic life support and advanced life support in the COVID-19 pandemic. The guidelines approved and disseminated by the European Resuscitation Council. The role of the trainings was for the rescuers to familiarize themselves with the equipment or disassembly of the protective materials and to adapt their rescue methods according to these protective materials. At the level of the General Inspectorate for Emergency Situations within the Ministry of Internal Affairs, the qualified first aid and release courses for firefighters has been cancelled. And this measure was taken considering, first of all, the prevention of the transmission of COVID infection during training among participants. Also, the trainers in the training centers helped their colleagues working in the pre-hospital to implement the new guidelines. And the course participants were used in the current intervention to transport patients to hospitals, as no medical training was needed, and they were used only as staff to ensure transport, given the large number of patients and the conditions of transport. According to the new guidelines, paramedics and medical personnel was instructed to limit the contact with the victim if the victim had specific symptoms to one crew member in the first phase. If the victim had to be transported to the hospital and there was a suspicion of infection, in order to limit the transmission of the infection, the victim was transported with an isolate, and all crew members were all protective equipment. Next slide, please. So for the mountain rescue, which is also coordinated operationally by the Department for Emergency Situations, where the law permitted, all legal provisions were taken in order to organize course. Of course, respecting the physical distance and disinfection of mannequin staff, ventilation of rooms, and all the other measures that had to be taken. As for the volunteers, the volunteer program within SMURD emergency department was cancelled during the state of emergency. And later it was transformed into a paid volunteer program to help the already volunteers that were working in the hospital and in the hospital with a large staff deficit. So this is mainly the situation in Romania. It was a challenge and still is. It's not over yet, but we are getting more and more trained to deal with it.
So thank you very much, Madlina. Your talk was very interesting too. I think that we finished this webinar in time, giving all the speakers to propose their projects and their conclusions. But I do believe that we reached the first main target that was to make the triangulation between practitioners, suppliers, and academicians. That is the focus of No Fear project. And we reached a very development of discussions about this triangulation.